Good morning, everybody. My name is James Baker. I'm an emergency medicine physician and an ACLS instructor since 1995. Today we're going to be reviewing the bradycardia algorithm for ACLS. The algorithm we're reviewing and the guidelines we're reviewing are taken from the American Heart Association 2010 guidelines based off this handbook from 2010 or the provider manual, which was published in 2011. The purpose of this video is to ensure that we give a preview and a review of material for students before they attend ACLS class. Viewing these videos will help the students get a head start on the material for ACLS class so that they come to class prepared and a step ahead of learning the material. This material does not completely or absolutely substitute for good clinical judgment in real-life practice dealing with real patients. The material is primarily meant for a review and preview before ACLS class. So in real life, use your clinical judgment when treating a patient. Okay, today we're going to review bradycardia, and we're going to start off with a normal rhythm. This is a normal sinus rhythm. Rate is 70. Normal rates are between 60 and 100, so we're at a rate of 70. You see it's a regular rhythm. The R waves are evenly spaced apart. There's a P wave followed by a QRS each and every time. The P waves get through to make the QRS consistently. So this is a sinus, normal sinus rhythm. Now we're talking about bradycardia. So the rhythm here that we're showing is slowing down. So it's a sinus bradycardia. Rate is 35, less than 60. So by definition, it's bradycardia. There is a P wave followed by a QRS each and every time. So that tells us the origin is sinus. The QRSs are narrow. There is no P waves that are hanging out loose with non-conduction. So this looks like a sinus bradycardia. The question you might ask is, well, is the patient symptomatic with this? And the answer is, well, it depends on the patient. You can have marathon runners, young marathon runners, that walk around with a resting heart rate in the 30s, and they're fine because they've got excellent cardiac output, excellent ejection fraction. So is sinus bradycardia always bad? The answer is it depends on your patient and on the clinical situation. Okay, so from sinus bradycardia, we're going to go to this one. And here we go. So you see the rate is 39, 43, 45, 48. It's climbing. Okay, let's look at the rhythm. P wave followed by QRS, P followed by QRST, P, QRST each and every time. So we would say this is sinus. But if you note, the PR interval is longer than what it was for sinus brady or normal sinus rhythm. There is no P's left hanging without conducting to make a QRS, so this is by definition a first-degree AV block. These blocks typically are not serious. Patients typically don't have symptoms, and they are not unstable. But it's a block you should be aware of because blocks can progress and get worse and worse and lead to higher degree blocks. Sometimes this block, this first-degree AV block with the prolonged PR interval, sometimes the patients aren't even bradycardic, and as you see here, the rate is 70. So this is a first-degree AV block. Okay, the next rhythm we're showing shows the P, QRST, P, QRST, P, whoop, and there's no QRST there. If you follow the PR interval, it's there, and it goes longer, longer, and then we have a dropped beat. So it's kind of warning us that a dropped QRS complex is coming. Longer, 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 drop. Normal PR, longer, longer, drop. So that warning starts with W, like Winky Bach, and that's the answer to this one. This is a second degree type 1 or Winky Bach type of block. Patient is bradycardic, less than 60. The question you need to ask yourself is this patient symptomatic with this block? This block is like the first degree, usually not serious. Patient usually will not be unstable. However, in real life clinical practice, anything can happen. You need to assess the patient's symptoms and their degree of instability. Okay, we're going to go to the next rhythm. And you can see P, Q, or ST. Oh, then there's a P hanging loose. P, Q, or ST. Looks like there's a P wave, and then P, Q, or ST. So by definition, some of these P's are getting through, but there's 1, 2, 3 others that need to happen before a Q or S gets through there. So this is, by definition, a second degree type 2 block. There's no warning like the Winky Bach for us. In fact, it's unpredictable when the P's are going to get through to make a Q or S. In real life, this could be a repeating pattern like you see here, or it could be a variable block. This is a higher degree block. This is a more serious block. This is a block that you need to be vigilant about and closely monitor your patient and institute treatment if they're symptomatic. This is a second degree type 2 or a Mobitz type 2 block. And here's the final one. You see wide QRS complexes. Looks like a P gets through to make that QRS, but in actuality, if you march it out, it just happens to fall there by coincidence. So if you march out the P's, they will march out, meaning they are beating at their own beat. They're marching to their own drum. The QRSs are marching to their own drum, but there's no connection between the P's making the QRSs. So this is a third degree AV block or a complete heart block or complete AV dissociation. None of these P wave signals are getting through to make the QRSs. So the QRSs are creating the heart is creating its own ventricular escape beats. This is the most serious degree of block. This is potentially the most unstable, and your patient likely is probably going to be symptomatic to some degree. So let's go ahead and review all of these bradycardias and all of these blocks. The whole idea of this algorithm is our patient exhibiting signs and symptoms? If we present you with a patient that comes to us with symptoms, as our algorithm shows up here on our board, you need to assess the clinical situation. If the patient's heart rate is less than 60, or as the board says, less than 50, you've got to really assess if the patient is symptomatic. So all patients, we're going to do our mantra of IV O2 monitor vital signs. So we're going to place the patient on O2, put an IV in them, get them hooked up to the cardiac monitors. When I say cardiac monitor, I mean for the rhythm on the EKG and pulse ox. Obviously, airway, breathing, circulation, and we're going to get an EKG if we have time. Once we get our vital signs, IV O2 monitor vital signs, once we get our vital signs and we assess the patient, we need to ask, is this bradycardia creating symptoms? So, symptoms of bradycardia would be any kind of symptoms of hypoperfusion or shock. So blood pressure is one of them, and typically we're going to use a blood pressure less than 90 to qualify them as hypotension. Or do they have altered mental status because of poor perfusion, poor blood pressure output? Do they have any signs or symptoms of shock? This can be cold, clammy, diaphoretic skin, pale, altered mental status, any signs of shock? Do they have chest pain? Do they have shortness of breath or pulmonary edema or signs of acute heart failure? If the answer to any of these is no, if your patient has a great blood pressure and they have no symptoms, then you're going to monitor closely and observe. However, if you've got any of these symptoms in your patient, if the answer is yes, you've got to begin treatment because your patient is unstable. They're having symptoms. And remember, we have 4 treatments for symptomatic bradycardia. First line treatment is always atropine. And the dose of atropine is going to be 0.5 milligrams IV push. And if our patient is awake and alert and their symptoms are minimal, typically we're going to start with that 0.5 milligrams IV push bolus. If our patient is really symptomatic and in bad shape, it's acceptable to go ahead and use 1 milligram IV push of atropine. You're going to repeat whatever dosing you give every 3 to 5 minutes up to a maximum of 3 milligrams. That's for an average adult size 70, 75 kilogram person. You go up to a maximum of 3 milligrams. If your symptoms have not resolved after 3 milligrams, atropine is not going to work. You can stop using the atropine and move on to a second line treatment. Our second line treatment, first one would be dopamine infusion. And the dose of dopamine is 2 to 10 mics per kilo per minute. You're going to start with that infusion dose and titrate up. Dopamine will also support blood pressure, but it also is chronotropic, meaning it will help stimulate the heart to increase its rhythm, increase cardiac output, increase the number of beats per minute. So it's chronotropic effect. If the dopamine doesn't work, you're going to move to an epinephrine IV infusion. The dose also is 2 to 10, but this one is 2 to 10 mics per minute. Mics per minute, whereas the dopamine was mics per kilo per minute. Again, you're going to start at 2 to 10, and you're going to titrate up to clinical effect. Again, the epinephrine supports blood pressure, but it also kicks the heart chronotropically in order to increase its rate. Along with the atropine, the dopamine, and the epi infusion, we've got a fourth line treatment, which is pacing. And here we go over to here, which is transcutaneous pacing, or abbreviated TCP. So our transcutaneous pacer, oftentimes we're going to call for this first because sometimes it takes a while to find the pads, to hook it up to the patient, to get it hooked up to our monitor. So we're going to call for this first while we're calling for the dopamine and epi infusions to get those hung. So let me show you transcutaneous pacing here. On our monitors in this hospital, every monitor is a Philips monitor, and we have these backpack pockets here. In the back of many of these, we're going to find pacing pads. Okay, so we're going to open up our pacing pads, and we're going to look at the pictures, and the pictures are going to tell us where we're placing the monitors. So this one is going to be right upper chest. This one's going to be left lateral chest. These are multifunctional pacing pads, which can allow us to monitor, pace, and deliver a shock if we need to. These are multifunctional pacing pads, hands-free pads, which are safer than picking up the traditional paddles off the monitor. So you're going to peel these stickies off, and on our patient here, we'll call him Mr. Blue. We've already got these hooked up to our patient, right upper chest, left lateral chest wall. These monitor pads have a cable attached, and we need to hook this up to our monitor so it works. Many monitors will have the gray cable attached because the gray cable is already hooked up to our manual paddles. American Heart Association guidelines suggest that we don't use these manual paddles if we can help it. It's much more safer to use the multifunctional pacing pads. So what I'm showing you here is you see the gray pads attached to the gray cable and the gray input here. We need to switch out this gray input by simply moving the green dial and pulling out. In the back of our pockets, we're going to find the black cable. we're going to pop the black cable in, and the end of the black cable gives us this connection, which fits perfectly into our multifunctional pads, which is on our patient. So now our system is set up. Now it will work. So to pace somebody, to begin transcutaneous pacing, you can see we're going to switch to pacing mode, right to there. And this is an artificial setup, so I'm going to get a box that says apply pads. Okay, I've already have my pads hooked up, but because it's not a real patient, the monitor doesn't recognize it. It's telling me to apply the pads, which I already have. So number one, turn it to pacer. You see our 3 dials down here. Number 2, first one we're going to be start pacing, pacing rate, pacing output. So typically you can start with pacing rate. I'm going to push that button, and it's going to pop up how many beats per minute, 70. I typically start with 60, and then we will titrate up if we need to. So I'm going to click that in place. I'm going to go ahead and do start pacing, and I'm going to start with my output, my pacer milliamps. So it's going to start out low. Here's 30 milliamps, and I'm going to assess to see when I have electrical capture on this patient. So I don't see electrical capture yet. We're going to go up to 35 milliamps. Nothing yet. 40. Nothing yet. 45. Nothing yet. Let's go up to 50. And let's see what happens at 50. There we go. Aha. Okay, so at 50 milliamps, we see a QRS spike followed by a wide QRS each and every time. So this illustrates that we've reached electrical capture with our transcutaneous pacer, and it's consistently capturing each and every time. Spike followed by a wide QRS. Whenever you see electrical capture on the monitor, you've got to correlate this electrical capture with mechanical capture on our patient. So if we show our patient here, in our ACLS classes, we make you go through the motions by assessing if our patient has a pulse. And where do we check a pulse at? Typically at the carotid artery. And so we're going to have you actually go through the motions and palpate a pulse and tell us if you feel mechanical capture. Now the instructor can control the pulse, but I'm going to hide this because I want you really to go through the motions and tell me if you feel a pulse or not. And if you feel a pulse, which seems to match the rate on the monitor of 79, then that tells you this electrical capture is translating into mechanical capture. And that's what we want. So if we've increased his pulse rate from a bradycardic situation up to a pulse rate of 70, 79, the next question is, what's the patient's blood pressure? And hopefully the blood pressure is above 90, and our patient is feeling better, and the symptoms have resolved. Oftentimes with transcutaneous pacer, we might need to sedate the patient or provide them with some pain medication because there is an electrical impulse being generated here. Okay, and I think that concludes our review of the algorithm for symptomatic bradycardia. Remember, there's 4 treatments for symptomatic bradycardia: atropine, dopamine infusion, epinephrine infusion, and the application of the transcutaneous pacer. Of note, those doses of dopamine and epinephrine infusion, know those doses we just reviewed for bradycardia, and remember, those doses are slightly different than the doses that we use for post-resuscitation care. For post-resuscitation hypotension, the dopamine and epinephrine infusion doses are a little different. So be sure you know the differences between those doses. And one final thing for this bradycardia algorithm, remember symptoms, assessing symptoms, and if the patient is unstable. A patient that comes in with hypotension, blood pressure 70/50, pale, cool, diaphoretic, and whatever bradycardic rhythm or block rhythm that they show, your patient is symptomatic. You've got to institute those treatments of start with atropine, dopamine, epi, transcutaneous pacing. You only need one. If the atropine works, you don't have to go through to the rest of them. But if atropine fails, you've got to proceed down the list until one of those treatment maneuvers works. Okay, that concludes our review of the bradycardic algorithm for American Heart Association. Hopefully you've enjoyed the video, and good luck in your ACLS class.